So picture this. We're starting with a massive red herring today. Imagine a 52-year-old patient who walks into the clinic presenting with all the classic textbook signs of a non-ST elevation myocardial infarction, an NSTEMI, or, a heart attack. But hidden right beneath those blaring cardiac alarms, he was actually harboring a slow-growing, silent threat that literally almost slipped past every standard diagnostic net we have. Here's the quick roadmap for our investigation today. We'll be looking at a deceptive presentation, the imaging pivot, a false sense of security, the silent culprit revealed, and finally some key clinical takeaways. Starting off with Section 1, a deceptive presentation.
Let's look at our patient's timeline for a second. He's a 52-year-old guy. 16 years prior to this presentation, he had a bicuspid aortic valve complicated by a group B streptococcal infection, and that required a surgical aortic valve replacement. Fast forward to just 1 year ago, and echocardiograms showed that this bioprosthetic valve was functioning perfectly. But then, on day 0, he arrives at outpatient cardiology. He's got a week of worsening shortness of breath and some new chest tightness. Crucially, though, he totally denied having any fever, edema, or constitutional symptoms. I mean, none of the typical inflammatory signs you'd actually expect to see with a serious infection.
Now, looking at the presenting EKG, you can clearly see nonspecific ST wave changes. Specifically, these new T-wave inversions in leads I, AVL, and V4 through V6. When you compare that to his baseline EKG from 2 years prior, well, the changes are glaring. Couple this new EKG with his lab results, we're talking an elevated high-sensitivity troponin sitting at 86 picograms per milliliter, an elevated brain natriuretic peptide, and heavily elevated D-dimer. The clinical picture is screaming heart attack, right? So he was admitted with a suspected NSTEMI and immediately placed on a heparin drip.
But hold on, because here is where the case gets really complicated. They rushed the patient to the cath lab for a left heart catheterization. As you can see, his coronary arteries were perfectly clear. I mean, completely zero blockages, absolutely shattering the heart attack theory. So the team is suddenly faced with this massive diagnostic paradox. They have all the biochemical and electrical signs of cardiac distress, but absolutely no ischemic cause.
Moving on to Section 2, the imaging pivot.
So, here's the crucial point. The standard transthoracic echocardiogram, the TTE, did reveal a new intravalvular leak and worsening gradients across his 16-year-old bioprosthetic valve, but it couldn't definitively tell the team why. To really see what was going on with that prosthetic valve, they had to pivot. They needed the superior sensitivity and specificity of a transesophageal echocardiogram, or TEE, which gives a much closer, clearer look at those critical cardiac structures. And this mid-esophageal TEE image provided the massive breakthrough. It clearly revealed a 1.3 centimeter echo-dense mass attached right to the non-coronary cusp. This was highly suspicious for vegetation, which pivoted the diagnosis entirely away from a heart attack and straight toward prosthetic valve infective endocarditis.
And the situation was getting dire. The color Doppler on the TEE further confirmed the severe mechanical dysfunction caused by this hidden lesion. You can see the turbulent flow, which indicates moderate to severe eccentric aortic valve regurgitation right alongside worsening stenosis. The valve was basically failing rapidly, and an emergency retothoracotomy for valve replacement had to be planned right away.
Which brings us to Section 3, a false sense of security.
You'd think they had it all figured out by now, right? Well, despite that alarming mass seen on the ultrasound, the lab results were entirely uncooperative. 2 early sets of blood cultures? Negative. Extensive infectious serology, testing for Bartonella, Coxiella, Q fever, Legionella, the whole shebang, all returned totally negative. But here is the most baffling part. When the cardiothoracic surgeon actually opened the patient up for the redo valve surgery, the intraoperative macroscopic exam showed absolutely no overt signs of infection or vegetation to the naked eye. None.
Faced with these negative labs, the complete lack of systemic inflammatory symptoms like a fever, and a totally sterile-looking surgical field, the clinical team made a really logical assumption. They concluded that the mass they saw in the echo was probably just debris from a degenerating 16-year-old bioprosthetic valve. The postoperative echo showed the new valve was working perfectly. Because of all this, empiric antibiotics were discontinued just 2 days after surgery, and the patient was discharged on day 12 without any antibiotics at all. It seemed like a totally straightforward case of mechanical valve failure. But that leads us straight into Section 4, the silent culprit revealed.
14.
That is the agonizing number of days it took for the actual truth to finally surface. See, during the surgery, 3 samples of aortic fluid and tissue had been sent off for prolonged culture. It took a full 14 days for just one of those 3 samples to finally grow a colony in the microbiology lab.
The silent culprit? Cutibacterium acnes. Now, you might actually recognize that name. It's a fastidious, slow-growing, gram-positive commensal skin bacterium. Yeah, it's the one that causes everyday acne. But when it manages to enter the bloodstream, it acts as an opportunistic biofilm-associated pathogen. It actually accounts for about 6% of all prosthetic valve endocarditis cases.
And this highlights exactly why C. acnes is so incredibly deceptive and why it nearly got away here. It creates this subclinical, indolent course that totally lacks the hallmark inflammatory responses we expect to see. Things like fever or elevated white blood cell counts. The vegetations it forms can be so tiny they are literally invisible to the surgeon's naked eye. On top of all that, the patient had been given broad-spectrum antibiotics right after the initial TE, before the first blood cultures were even drawn. This is a well-recognized cause for false negative blood cultures, effectively masking the bacteria entirely. Thankfully, though, the infectious disease team remained super vigilant. Once that slow-growing culture finally turned positive on day 14, they immediately reached out to the patient. He was quickly recalled to the hospital and put on a full 6-week course of intravenous ceftriaxone via a PICC line right at home. Thanks to this incredible catch, he made an excellent recovery with normal valve function on his follow-up.
Let's wrap this up with Section 5, Key Clinical Takeaways.
These takeaways are absolutely critical and perfectly echo the American Heart Association guidelines. First up, you absolutely must use a TEE for suspected prosthetic valve infections because it can detect those subtle lesions that standard echoes just miss. Second, fastidious organisms like C. acnes require prolonged culture times. Think about it. If they had thrown those cultures out at standard intervals, this patient would have gone untreated. Third, whenever possible, cultures must be drawn before broad-spectrum antibiotics are administered to avoid masking the infection. And finally, navigating this level of diagnostic uncertainty requires tight, multidisciplinary collaboration between cardiology, surgery, and infectious disease specialists. The authors of the source report actually sum it up perfectly with this quote right here. Clinical suspicion must remain incredibly high when prosthetic valves fail. If you have a patient with a prosthetic valve, male gender, and prior cardiac surgery, the absence of a fever or a negative early blood culture absolutely does not rule out an active destructive infection. Which leaves us with a pretty powerful final thought. If a destructive heart infection can perfectly disguise itself as a standard heart attack and evade multiple rounds of rigorous testing, we really have to ask ourselves, what other silent diagnostic threats are hiding right now behind our typical patient presentations? It's a huge reminder to always question our diagnostic anchors and look way beyond the surface. Thanks for joining me on this explainer deep dive. Keep questioning and keep learning.